Good morning. Today we are going to discuss the Vesical Imaging Reporting System, the Inter-Observer Agreement and Impact of Readers' Experience. This is my disclosures. Bladder cancer is the most common tumor in the urinary system. Urinary bladder cancer is more common in males than females, and 90% of bladder tumors are TCCs. The bladder cancer is classified histopathologically into non-muscle invasive bladder cancer and muscle invasive bladder cancer, and this is of cornerstone in therapy planning for these patients. The imaging modalities for evaluation of bladder cancer includes ultrasound, however, and also CT. However, they have limited performance to assess muscle invasion. They are only used for detection and staging for extra vesical components. Cystoscopy and the TURBT is still the gold standard for evaluation of muscle invasive bladder cancer. And then implementing the MRI is a very helpful tool in evaluation of bladder cancer and the proper tumor staging. And so, as regards the MRI, the VI-RADS scoring is developed, which is including multi-parametric imaging to evaluate the bladder cancer and to evaluate the degree of muscle invasion and the possibility of muscle invasion. This VI-RADS scoring depends on having T2 weighted image, diffusion weighted image, and the DCE. This is a normal MRI for the bladder. This is the T2 weighted image showing that the muscle layer appear as a dark signal on the T2, while on the diffusion, the muscle layer appear to be intermediate on the DWI, and the DCE, the mucosal enhancement is only visualized on the early DCE, while the muscle layer is showing just delayed enhancement. So how to evaluate non-muscle invasive bladder cancer with the disruption of the low signal intensity of the detrusal muscle layer? This is a non-muscle invasive bladder cancer. And if we didn't find any disruption of this muscle layer, then this tumor is staged as T1 tumor or low. While muscle invasive bladder cancer is detected when there is a regular wall, interruption of the muscle layer, and focal enhancement on the early DCE for the muscle layer, and also focal wall thickening around the tumor. All these are MRI signs for muscle invasive bladder cancer. Then we perform a final VI-RADS scoring for the evaluation of the possibility of muscle invasion from VI-RADS 1 to 5, where 5 is the most likely muscle invasive bladder cancer. Our aim of work is to evaluate the inter-observer agreement according to the observer experience, and also to evaluate the diagnostic performance of the VI-RADS to differentiate between muscle invasive and non-muscle invasive bladder cancer. This our patients group. We performed this study in Ain Shams University Hospital since April 2021 to October 2021, and 30 patients were included, including males and females. The inclusion criteria includes patients with diagnosed bladder cancer by any imaging modality. No biopsies were performed to avoid the bias for under or overestimation of muscle invasive disease, with no age or sex predilection. The exclusion criteria includes any contraindication for IV contrast injection as allergy or renal impairments. Also the patient with the general contraindication to MRI as claustrophobic patients, and also patients who had underwent TURBT and will not fit for TURBT, so that we can confirm our results with the biopsy. And the patients who pathology revealed non-TCC bladder cancer. MRI technique needs some preparation, with the fasting for about 2 to 6 hours before the exam. Kidney function test is mandatory. Sometimes we use anesthesia for some selected patients, and we advise the patient to evacuate the bladder 1 to 2 hours before the exam to allow proper distension of the bladder with no over distension, to allow the patient to be comfortable during performing the exam. The exam was performed on 1.5T MRI in a supine position, and we performed this protocol including T2 weighted image in the 3 orthogonal planes, and diffusion, T1, and the DCE. Then we observe the findings by 3 different readers with different experience in imaging of the bladder cancer, from a non-experienced radiologist, she was a resident with us, and 2 experienced radiologists with 5 and 15 years of experience. And our results included 31 male patients and 7 female patients, with most of the tumors were located in the lateral wall. The total lesions were about 43 lesions, with 12 were non-muscle invasive and 31 were muscle invasive bladder cancer. And the total lesions, some of them are low-grade tumors and others are high-grade tumors. In spite of being non-muscle invasive, we can still having G2 or G3 tumors. So when we apply the cutoff value of VI-RADS score 3, we have an overall sensitivity and specificity that is very good among 3 readers compared to the pathology. And this was also having a very good inter-observer agreement between the readers regarding their experience in comparison to the pathology. Let's demonstrate some of our cases. This one patient was coming actually for evaluation for the prostate in a multiparametric MRI, and we noticed this small bladder polypoidal lesion at the anterior aspect of the bladder neck. This is the sagittal T2 weighted image, and this is the axial T2 weighted image with the speculated polypoidal lesion, and this is the dynamic study showing hyper-enhancement of the lesion. When we look close in the GWI, we can see that there is a non-restricted central part of the mass, while the mass itself shows restriction. And this is called inchworm sign, and this is a clue for non-muscle invasive bladder cancer. This was confirmed on the ADC map with non-restricted central part, with restricted the rest of the polypoidal bladder lesion. And this is the DCE showing the delayed enhancement of the polypoidal peduncle. And the final score was VI-RADS 2 by all 3 readers, and it was confirmed to be non-muscle invasive bladder cancer. The second patient.
Your conclusion, Dr. RASHA?
Yes?
Your conclusion, please, because we run out of time.
To sum up, the VI-RADS was designed to implement and create a structured reporting system for interpreting multiparametric MRI for local bladder cancer staging. VI-RADS have an excellent diagnostic performance in discriminating non-muscle invasive bladder cancer and muscle invasive bladder cancer. Also, it has a very good inter-observer agreement. In spite of the least experienced reader, still the agreement was very good with the pathological data. Thank you.
Thank you, Dr. RASHA, for a nice presentation.